The next one that we're going to focus on is intra-articular anesthesia of the coffin or distal interphalangeal joint. Now, there are different ways of injecting this joint. People come slightly from the side to go underneath the extensor tendon without penetrating it. Some people direct the needle vertically, perpendicular to the bearing surface of the foot. I like to go horizontal with the needle, just proximal to the covering band, as the proximal pouch, dorsal pouch, of the coffin joint distends somewhat proximally, enlarges proximally, and I think I can hit it more consistently by doing this. So 5 cc of mepivacaine in the coffin joint results in what? Desensitization of the coffin joint, obviously, the DIP joint. But looking at the early MRI studies that came out on the diagnosis of collateral ligament dysmitis, the collateral ligaments are generally not very well desensitized by intra-articular anesthesia. There's about 20% or so had improvement, but about 75% did not. The navicular bone is desensitized by injecting the coffin joint. The navicular bursa is desensitized. The toe region of the sole is desensitized. And the heel region of the sole is also desensitized if you use a larger volume. If you use a 10 cc volume, or you wait up to half an hour, the heel region of the sole will also be desensitized. And then, of course, the distal portion of the deep flexor tendon is desensitized in a large number of horses as well. So if we represent this on this anatomical slide, we inject the coffin joint with local anesthetic. What will be desensitized? Anything that's going to be blue. So the coffin joint, the navicular bone area, including the navicular bone, the distal impar ligament, the collateral sesamoidean ligaments, the navicular bursa, the distal portion of the deep flexor tendon. In addition, the toe region of the sole will be desensitized. How did we find this out? By putting these 6 screws in the toe region of the sole and tightening them until the horse was as lame as you saw it on the video, doing coffin joint anesthesia and seeing these horses go sound will very significantly improve. And not just in one horse, but repeatedly. And then the heel region of the sole should normally not be desensitized if you use a 5 cc up to 6 cc volume and don't wait any longer than 10 minutes to assess the result of the block. After 10 minutes, who knows what happens, but within 10 minutes, the heel region of the sole should not be desensitized. So what is the mechanism? Diffusion does occur. People have done studies to look at presence of mepivacaine in the synovial fluid of the navicular bursa, presence of methylene blue in the navicular bursa, contrast agent also diffuses if you wait long enough. But is diffusion the main mechanism? Probably not. What is probably the main mechanism is direct contact between the local anesthetic agent filling the palmar pouch of the coffin joint, which, and I think this is a drawing, an image from one of John Marie's publications, where the coffin joint has been filled with latex, and you can see that this pouch sits right where the palmar-digital nerve runs down into the foot. And we'll talk more about this in a minute. Now, because this contact area here occurs distal to the site where the heel branches come off the palmar-digital nerve, there should be no desensitization of the heel region of the sole, because sensation remains intact in these branches. Okay? If you inject the coffin joint, we speculate that the contact area between the palmar pouch of the coffin joint and the palmar-digital nerve occurs distal to where the heel branches come off. However, if you use a larger volume, double the volume to 10 cc's, the pouch will enlarge sufficiently for that contact area to occur more proximally, and the heel region of the sole will also be desensitized. Or if you wait long enough and diffusion occurs proximally. Here is a slide to illustrate this. On the left, a coffin joint injected with 4 cc's of local anesthetic, of contrast medium. On the right, a slide injected with 7 cc's. And you see how the proximal palmar pouch of the coffin joint, or distal pharyngeal joint, enlarges just by adding 3 cc's of contrast. So if you go up to 10 cc's, you can imagine that this pouch would be even bigger. Here is another interesting slide that illustrates this. Here is a slide that shows you the proximal-distal diffusion after contrast has been injected at a palmar digital nerve block. So inadvertently, this nerve block with contrast is outlining the palmar digital nerve. Okay. Now look what happens after the coffin joint is injected with a mixture of air and contrast. The attempt was to get a positive contrast arthrogram. But what we get here is we can see on this oblique radiograph this palmar pouch bulging and displacing the palmar digital nerve in a palmar direction, showing that there is very close association between these pouches and the palmar digital nerves. And that's why we speculate that there is direct contact here that is responsible for anesthesia of the palmar digital nerve at this site, following coffin joint anesthesia. So the clinical interpretation leads to say that coffin joint anesthesia with a low volume of local anesthetic, 5 cc's, may differentiate between palmar heel pain, because the heels should not be desensitized, and navicular region or podotropial pain, provided you have first eliminated the presence or absence of pain in the sole, specifically in the toe region of the sole, because that will also be desensitized following coffin joint anesthesia. So use your hoof testers before you start blocking things. What conclusion can be made if coffin joint anesthesia is negative? In other words, can we rule out podotropial pain if coffin joint anesthesia is negative? And for that, we look at some historical data from a paper by Sue Dyson that came out of the Animal Health Trust, 102 horses that were examined for foot pain. And the comparison was made between their response to, on the one hand, coffin joint anesthesia, on the left here, and on the other hand, bursal anesthesia. So all of these 102 horses had both techniques performed. And here you see the distribution of these 100 and so horses. 66% were positive to both bursa and coffin joint, 21% were positive to bursa and negative to coffin joint, and then you had 15% that were negative to bursa. So if we take as the definition of navicular pain a positive bursal block, I know that now includes deep distal flexor tendon pain, which we didn't really realize yet in 1995. But if you define navicular pain as a positive bursal block, you can see that there's about 20% or so of the horses with navicular pain that remain negative to coffin joint anesthesia. The conclusion therefore has to be that negative coffin joint anesthesia does not rule out the presence of navicular region pain, and that there is a 1 in 5 chance that even with a negative coffin joint block, the horse will still be suffering from navicular pain.